I'm 58 now, and I didn't even know it was related to my hormones. I had the vertigo, I had the frozen shoulder, I had the dry skin, all these things that sound like they're not a big deal. Well, frozen shoulder was a big deal, trust me. The sleep, the 8 pounds around the middle that just seemed to come from out of nowhere, doubling my basal rate. And this is when I was doing my daily injections. So I went from 9 units a day. And I know this is a number that maybe the listeners don't understand, but 9 units of basal insulin. So this is a 1 day shot. So I went from 9 to 15. So nearly doubled within, again, it was a slow gradual. It wasn't overnight, thank goodness, but we notice these differences. We notice when 10 units is not quite enough. Oh, I got to up it to 11. Oh, I got to up it to 13. Okay, so when does this stop? What is the reason why? And that's when I kind of put it together for myself that it really had to do with the estradiol that was pretty much doing a nosedive in my system.
All right. Well, it's a real pleasure to have Melissa Slemp on the show today. Welcome.
Well, hi, Zora. Great to meet you and to be here.
I'm so glad we connected. You've got a great podcast as well, helping women with type 1 diabetes, which is a topic that we haven't covered yet. And it's a whole cohort of women who are probably feeling really lost in this menopause space. And so I'm so grateful that you're here providing information for them because they may need some things that are very specific to them. I'm excited to share you with our audience here. And I'd like to share your story first because you were diagnosed with type 1 diabetes when you were 14. So you've been in this game for a long time. So
Long time.
tell us a little bit how that shaped your path into nutrition and hormone health and coaching.
Yeah, it's been quite a journey. So 43 years, and it didn't start off pretty. Again, this is 1982. So if the listeners are not familiar with the technology, but the medical technology that we now have to manage this disease is quite the blessing. It's really does make a difference. So 1982, we didn't even have a glucometer. I didn't have a way to test my blood sugar, which sounds crazy. So we had urine strips, which sounds yucky, but that's all we knew. And it would give you a color range. So you'd look at the chart and it was yellows to reds, I think, if I can remember correctly. And depending on the shade of that result, kind of gave you an idea. But as you can imagine, it was a very rough idea. So that was not something that was even very something I was compliant with, just based on how you had to do it. And fast forward my teenage years, and it's so interesting because now I have come full circle with hormones. So I know that was a big impact of how I was unable to manage well in my teenage years because hormones was such a big part of the disruption. Now I'm in postmenopause. I'm so thankful to now understand it now. I wished I knew it then. But now that's really my mission is to help educate women of all ages diagnosed with type 1. But I was a hot mess, literally. And just disconnected from my disease, the monitoring of it. My family and I, we grew up, it was very minimal. We didn't have a lot. Even getting a glucometer wasn't in the budget, believe it or not. And test strips back in those days were more expensive. So it wasn't as attainable for me to really not number one, understand blood sugar, but how to manage it. So I just tossed it aside because again, there wasn't an importance placed on it. So I decided, I think, just naturally, I think I decided that it just wasn't a big deal. And then 10 years later, when I was just newly married, I was 25, is I woke up one day and I had what is now something that I understand now what it is. At the time, I had no idea, but it was floaters. So basically, the retinas in the back of my eyes, the vessels were bleeding and I was seeing blood. And so that was a wake up call. So again, 10 years in, and I'm like, oh. And I remember my doctor, my ophthalmologist, I was so thankful. I had a great team of doctors. I'd never even been to the eye doctor before. It's my first eye visit at 25. And he's like, well, consistent high blood sugars unfortunately can get you here. And that's really my story. And he said, you've got to get these numbers. And again, my doctor at the time obviously piggybacked with that advice. So I got the glucometer out then. I literally pulled it out of the drawer and got the test strips. And I was off and running because I was being told I could go blind, that this was not going to get better unless I made some better decisions about just understanding this disease and how important blood sugar was.
Can I interrupt you for 1 second?
Sure.
I just maybe realized that perhaps people may not know the difference between type 1 and type 2, because when we
Sure.
say the word diabetes, most often people are hearing type 2. And yes, we can reverse this, but type 1, you cannot. Is that correct?
Right. That is absolutely true. As of now, so this is 2025, there's a lot of great things happening in the research end, but no, there is no cure, no, not or available cure at this time. So right now we live with an autoimmune disease where one day when I was 14, in my case, my body just decided to destroy my islet cells. So the islet cells that produce insulin in my pancreas just completely shut down.
Do you know
And
why? Sorry.
good question. And I don't think I'll ever know why. There's theories around stress, maybe another viral load that might have triggered the antibody that was present in my system. They're learning a lot more about this nowadays. There's a lot of great projects going on where they're really finding and they're looking closer at these antibodies. And this is a part of the community that's really exciting. So there's people that have obviously diabetes in their family. So maybe it's a parent that have children and they have their children tested for the antibodies. So this is great, and it's a great preventive way to maybe see if the likelihood will happen. There's a grading system, I guess, as far as those antibodies, as far as the levels that somebody may or may not carry. So I obviously had the antibodies at some point in my life and when I was younger, and something obviously triggered that to result. Yeah.
Did your parents or anyone in your family have type 1 diabetes?
No, I later learned, and this is just recently, I had some family members reach out. So I do have a second cousin, and I believe it's a niece on some other side of the family. So very distant relation. So whether or not that's a correlation, I don't know. To this day, I don't know. But
So what a
yeah,
surprise. Yeah, it's nothing you did wrong. It's nothing that
no.
happened from your part. It's nothing you control. Whereas type 2, you can control it. And this must be
Right.
so frustrating as a teenager, especially you're given this diagnosis, but how did you find out? And the other question I have, it's in my mind before I forget, is are
Sure.
people born with type 1 diabetes as well, like from birth? And how can you detect if you, or if this is your case?
Yeah, and those are all great questions. I think those are things that they're just trying to comb through as far as the evidence and the likelihood. And I do think these antibodies that they are able to test for do give a family kind of that inside, maybe this is going to happen, that inside tip. Again, information is powerful. I know you're big on levels and finding out the data. So for a family to know ahead of time that, hey, guess what? Let's keep an eye on this. I still don't see, and I'm not a medical doctor or researcher, if even if you possess or have these antibodies, if there's any way to mitigate that or to turn it around. That I'm not seeing as part of the that data that they're carrying or that they're studying. It doesn't make sense. You either have an antibody or you don't. So,
Hmm.
yeah.
So what was it like as a 14-year-old to be told this? How did you even come to the conclusion? What symptoms did you have?
Yeah, great question. And it's very common symptoms. It's the two main ones that everybody can definitely attest to is increased thirst. I guess cottonmouth is the term, but you can't get enough water. It's just constant thirst. And that's really the kidneys trying to really get rid of the sugar. So that's the whole mechanism happening in the body. So you are drinking water and going to the bathroom constantly. So it's constant urination as well.
Does it matter
Um,
if you have a lot of blood sugar in there or less blood sugar? Do you have more thirst, less thirst, depending on what you've eaten?
I would think the higher your sugar goes, the more extreme the symptoms are. I remember looking back at those symptoms. I remember those symptoms, but we weren't, and my parents, in this case, my family, they weren't cognizant of it or what it was or what it could be about. So unfortunately, my symptoms went on for, again, I don't know, how long did they go on? At what point does your body decide to kill that pancreas? And at what point does your body decide to slowly stop making its own and producing its own insulin? Those are questions that I don't think I'll ever know, but just So I ended up in DKA. So DKA is diabetes ketoacidosis. So that is extreme high blood sugar. And I remember it was the day before Easter. We had a two-story house. It was my older brother and I, and we were up there doing some things for Easter because it was the next day. I don't know, we were packing Easter baskets or something. And I remember just being delirious where I literally passed out. So I was at a very extreme level of DKA because I really was truly near death and hyperventilating. So I couldn't control my breath. And then at that point, my parents came and they whisked me off to the ER. And in those days, they kept you in the hospital for, gosh, I was there for a week just to get things kind of leveled out and get you on the insulin, teach you about how to do the injections. And again, there wasn't really any source to really test the blood sugar, so that wasn't something that I could do. That was something they could do in the hospital, not necessarily a tool that I could go home with. But
Did they diagnose you right away? They knew
oh,
what this
sure,
was?
they did. They sure did.
Oh,
Yeah.
that's life-saving because can you imagine if they didn't know, they're testing, and meanwhile you're falling apart without
Yeah.
insulin.
Good point. Yes.
So, how did they dose the insulin with you? Because you didn't have a way to monitor how much blood sugar you had running through the system.
Yeah. In those days, I remember, and this always reminds me of Weight Watchers because Weight Watchers has the exchange system. I'm assuming they still do it that way. I don't know. But that's what they said. Well, we're going to help you use the Weight Watchers exchange system. Again, this is 1982. And it was basically carbohydrates were giving a number of exchanges. And I don't even remember what the calculation was to this day. I'd have to look at a graph just to see how they did it. But they sent us home with that. And again, we were using pork and beef insulin. So this was insulin that was coming from animals. And it was in a vial. There was no pumps yet, no insulin pumps quite yet. They were close to coming, but not quite. And yeah, I was just drawing it up from the vial and taking 3 to 4 shots a day. And basically, take this morning, take this noon, take this at night, 3 shots a day, sometimes four, depending if I needed that other NPH. So it was NPH and regular. So that's really my only memories. And it's funny how some things stick out very boldly, but I just remember that's just what it was. It didn't really matter what I ate. I estimated it the best I could, but they just told me to take this amount of insulin for breakfast, this amount of insulin for dinner,
What
and
about
all.
you were snacking or something? As a teenager, I'm sure you must have. It'd
I'm
been hard
sure
to
I
control.
did. I'm sure I did. I don't remember taking shots. I don't remember taking insulin injections for snacks. I remember it being a morning and a nighttime dose in those days.
And
Yeah.
it worked out okay, or did you have trouble?
Looking back in those 10 years that I mentioned, where obviously I was trending high for 10 years. So I obviously did not have it properly calculated accordingly. Yeah. And it showed itself.
So when did the home testing come in? When was that available?
Hmm. I don't have the date of that. I want to say it was probably late 80s. Again, the glucometers they were bigger. Nowadays, they're so small and they only take like 5 seconds to give you a result. I remember they would take up to 2 minutes, which seems like a lifetime. But again, it was information. At least we were getting a number. Yeah, so those are things that we did have availability for eventually at
How
home.
old were you when you had your first one?
I think maybe my early 20s, believe it or not. So it took me 4 or 5 years to actually have my hands on one. Yeah.
But you did get them. Was this after you saw the ophthalmologist with your eye issue?
Prior, again, I was just putting it in the back seat. I have diabetes. I guess I'm doing it okay. I was an active kid. I think I had that going for me. That obviously helped to some point. I did not eat the healthiest. I can think back. It wasn't terrible, but it definitely it wasn't as great as I'm eating nowadays. It's so funny when you compare. Again, I didn't have the education around how important it is, and it will always be, and it's really something I had to focus on. So I think that's the biggest driver is lack of resources and the education. And the other thing was lack of community. I didn't know anybody with type 1 diabetes. So you feel very isolated. It's real easy to tuck things back and just put it in your back pocket when you go out the door that day because nobody else has it. Nobody else gets it. I'm just going to keep it to myself, do the best I can every day. And here we go.
How was it? In the 80s, we were, at least in the US, we were told that fat is bad and then the carbohydrates are great. So you must have really suffered in that
Right.
moment where everything was packed with sugar
You're so
because to
right.
give it flavor, because it didn't have any fat in it. So how did you navigate that space and how were you when you
That
found out?
Yeah, that's a great point because yeah, that was the 80s and 90s, low fat, sugar-free junk. It was a lot of packaged junk, and that's when that really hit the market. And I really thought that was a great thing because a lot of those things were measurable. I can remember the Snackwell's 100-calorie pack things. I was like, oh, cool, something, this package is telling me what I'm eating. Maybe that'll help me dose insulin. But I remember, again, I was a young girl that was always, I was cognizant of my weight and looking healthy, whatever that meant. So I always thought low fat. I was on the same bandwagon as all young ladies back in those days. So yeah, I was eating all the fake foods and the
So
sugar free.
then I guess you probably had to just increase the dosage of insulin. Is that
Yeah,
correct?
yeah. And that's what I later learned once I got dialed in with actually understanding dosing my insulin rather than just following the standard guidelines, which was 3 units for breakfast, 3 units for lunch, and 4 units for dinner. That's sort of a standard by the book where it wasn't personally prescribed,
Yeah.
which it obviously needs to. Again, we've come a long way in this space with diabetes for sure.
So when
Yeah.
the ophthalmologist told you better deal with your blood sugar levels, otherwise you're going to lose your eyeballs, that was probably a scary moment. And that's when you shifted into the health and wellness just space. I mean, just really
Yes.
dialing it in. And then is that when you got a glucose monitor in the sense, even if it took a long time, you were just
Yeah.
paying more attention and trying to dose less probably as possible, eating the right foods. Is that
Yeah, it's funny, Zora. It flipped a switch in me because I went from not caring to caring maybe too much because I went to extreme tight control. I'm talking many 911 calls. I'm talking extreme lows, passed out. It's just incredible how many of those that I chose to take the chance on because I did not want my blood sugars to ever be high.
and so it went too low, is that what you're saying?
Yeah, yeah. So I went from averaging high, not realizing how bad that was, to extreme tight control, so averaging too low.
Yeah.
And it really disrupted life, as you can imagine. My marriage, I had a daughter a few years later after that. I was lucky to go through a really healthy pregnancy. Again, I was in tune in those days, in tune with my blood sugar, in tune with wanting to keep a tight control because that's something we had to do during pregnancy with type 1 diabetes. It's real important. So I'm thankful for that. But later on, when she was a little older, so Sarah, she's now 29, and she works as a nurse. So it is amazing how it's all come full circle because she's always been just such a very matter of fact, loving, caring young lady. And I saw those traits in her when she was growing up because fortunately, unfortunately, there was times where she really had to take care of mom because mom couldn't take care of herself.
Is
It's
that because,
definitely a part of the story for sure.
so how was it that you couldn't take care of yourself? If
Low blood sugar, most definitely. And this is just a fast way to just give your listeners a little bit of insight about that. But when our glucose is low, our brain needs sugar. It is something our brain needs sugar to operate. We need it for decision making to help ourselves physically. Physiologically, we shut down. There's times where you're on the floor trying to help yourself to get orange juice out of the fridge, and you literally cannot move to get there. Your brain is trying to help you, but your brain and your body are not connecting. So it's just the power of glucose. I think we can get a little bit judgmental about glucose, myself included, but there is a need for it. There are definitely systems in the body that need it to operate. So there were times where I was unable to help myself, and my daughter had to step in and give mom something sweet to eat, or just to be able to sit quietly and to be able to get through that process as I was trying to recover from the low blood sugar. Yeah.
Incredible. Yes. I just wanted to give people a little visual. That's because it doesn't, we always think, oh, low blood sugar, let's get our blood sugar as low as possible, but we cannot go too low. And I
Sure.
think I told you, and we were having a discussion before, that I wake up in the middle of the night
Yeah.
kind of hungry if my blood sugar goes low. And I'm like, oh
Hmm.
God, I should have eaten something before bed. And I feel it. And if I wear the continuous glucose monitor, I see, oh wow, that's why I woke up last night. It's really, really important that we have it
Interesting.
in this sweet spot. And so it sounds like you, yeah, like you said, flipped the other way, became very diligent about what you ate or increasing the insulin, because that's one thing that you can do that I can't do. Like you can inject
Right.
yourself with insulin and bring it down. I'd
Right.
have to go and exercise, or I don't know, try
Right.
to get it out another way.
Hmm.
So did you notice? So it's interesting that you got to an extreme that you just literally couldn't hardly move. But did you see any fluctuations in your weight during that time?
With my weight, that's interesting. No, nothing too extreme across the board with that. After I got married, I actually worked in the business world. So I worked as an account in a company and worked accounting and business and all of that. And that was another whole shift because bringing a disease to your workplace, well, literally, because it's part of what you have to manage every day. But it is amazing how that impacts really those relationships. And it still creates a wall because you don't want it to show as a weakness. You don't want it to come up as you don't want people to feel sorry for you. So that's something that it took years for me to come to terms with that I can bring people in that I work with, let them know. And that's for safety reasons too. You want people that you spend 8 hours a day with to understand that if I'm passed out at my desk, it could be Melissa's blood sugar might be low. So it's important to have that communication. But it did create that kind of that barrier that I continue to work through. But I was always trying to stay healthy. And I know healthy is a broad term, but I've always been active. My diet, I will say, cleaned up as I was getting older. I went back to school, studied nutrition and hormone health and all of that. So I thank goodness, because I was thirsty for more information because I wanted to do this in a very holistic way and to feel better. And I wanted that steadiness to not only look good on the A1C report that I got done twice a year with the doctor, but also how I felt every day and my production at work and my relationships, all those things. So my weight was always pretty steady because I think I got on board with a steady trend of diet, exercise, sleep, all the things that I try to be consistent with these days. And that really was my secret sauce through all those years. And it just kept spurring my interest in learning more, knowing more. And then, of course, fast forward nowadays, working as a coach to help other women because, again, I didn't have that. These are things that I didn't have in my 30s, my 20s, and my 30s. And we can't change what we didn't have. We can't go back and rewrite the script, but I recognized that's really my gift. So I walked away from corporate. I was done with sitting behind the desk all day. And I studied some more, went back to school, and got my certifications to be able to help women. And yeah, that's really, and I've written about this, I've done articles, and I think we all are here for a purpose. You can take a disease that started so roughly for me and so vague. I'll say vague. I was just so detached from what it was. But knowing that my story was going to play out later on. And I can be on shows like this or my own podcast and meet with clients and share this because it's part of who I am. It's part of why I'm here. So I'm using diabetes as a gift. It's not something that I'm going to look back on.
Well, you have this and you have to live with this for the rest of your life.
Yes.
So I always say, if I can control it, great. If I can't control it, I have to let it go and do the best that you can. So in the end, I want to clarify and have a better understanding. I know that people with diabetes in general are at higher risk for all diseases of aging, and they have to be a little bit more careful. But
Hmm.
how is type 1 different than type 2, other than, or you can't reverse type 1?
Yeah, yeah, good question. I think the difference is number one, it's not just like you said, it's not going anywhere. I think the first thing we can do sooner than later is to accept it and to take it on. It doesn't define who we are. It's not my identity, but it's definitely something that I have to spend a lot of attention and care on. And I think for all of us, even with our health, I think ours living with type 1 is it's very rare to have a disease that in some cases it's hidden because you don't necessarily see those of us with type 1 walking around. But in a lot of cases, it's very exposed because our blood sugar control, I really hate the word control, but I'm going to use it in this sense. But just the blood sugar level, it speaks so loudly to everything, to how we feel and operate every day. And I think that would be one thing. I think that is the difference. I think either one, type 1 or type 2, is going to feel that impact. But I really think it's the relationship with what we want to see happen going forward with our health and turning it into a motivator rather than something that they just have to be, something they have to deal with
Or a victim?
or yeah, yeah, there's so many different layers and twists and turns about just understanding the difference. But medically, we do kind of live the same technically because in theory, we're trying to be aware and making decisions to help our blood sugar. Obviously, the difference with type 1 and insulin dependent is that we have to manually inject a hormone that's going to influence that outcome. Where somebody with type 2, or in the term prediabetes, which really is just the early stages of what the body is saying is no longer working productively, and that is your ability to process insulin, utilize insulin. And there's a lot of other factors that go into this because I know these are things, lifestyle is such a big umbrella. And really, I think sugar, because it's so inflammatory, that really is the first sign, I think. And it does tend to be one of the first diagnoses of people is it's blood sugar. Or it might be cholesterol. It might be blood pressure. All these things that kind of fit in that same sort of inflammatory box. It really is. But I think in general, and I've heard a lot of doctors and experts in this field talk about this, it all goes back to insulin.
So a
You know,
type 1 isn't more at risk for Alzheimer's, for example, than a type 2. Do we know?
uncontrolled, either one, uncontrolled can definitely, again, inflame the systems of the body. So
Mm.
definitely, absolutely. And I think another thing that happens with us with type 1, again, it does depend. It's very individual because it really depends on our level of care, what our average blood sugar is, obviously, other things that are in our lifestyle that are going to help and support this. And another thing that we don't always maybe hear too much about, I think maybe we talk about this more in the type 1 community than maybe the type 2 community, but the fluctuations is really where all the trouble comes. So it's the roller coaster that is really doing so much damage to not only our body, but everything we're trying to do every day. If you have a chance, like you have, to wear a CGM and you can get that feedback and realize that, oh, okay, well, this is why I don't feel like doing X, Y, and Z. Oh, that those carbs I had for lunch really did kind of shoot me up. And now my body is working really hard to produce a lot of insulin to bring it down. Well, think of that roller coaster and how much stress that puts on the body. So I think that is the difference because with type 2, if you're not aware of what's going on behind the scenes, you're kind of disconnected to really how you're feeling. And then long term, what's going to happen to your health. So the A1C is wonderful. The glucose, that fasting glucose that you get when you have that office visit twice a year, yeah, that's all good. But it's just a little snapshot, isn't it? It's not telling the whole story.
Yeah, it's
Yeah.
interesting. You mentioned CGM, just in case people don't know what that means. That's a continuous glucose monitor. Do you have one on now that you can show, or?
I do. Let me
Yeah. So
see. Yeah, I'm wearing both my goods. So I've got my insulin pump. This is giving me the insulin. And then my CGM, which is a Dexcom G7. So that's the new model of the Dexcom. And those two systems actually work together, speak together, which is really neat. Yeah.
Oh, how great. So people who are just listening, the continuous glucose monitor is the size of a, I don't know, a silver dollar, I
Kind
guess,
of a,
or a
yeah,
quarter.
quarter maybe. Yeah.
Yeah, and so it's this little round thing, and you see people walking around all the time. I wear it, and people, oh, you're diabetic. I'm like, no, I want to see
Curious.
my blood
Yeah.
sugar. But then you have this other device. It's a little block the size of a, I don't know, small cards of crayon, or I don't know, deck of
Yeah.
cards.
Hmm.
But it's interesting that the two work together because last time I spoke to you, you said insulin pump. And I said, what does that look like? And you had one on your belly, right?
Yeah, that's right. I was wearing it on my belly. Uh-huh.
So
Yeah.
it's the same device. Can just move it around.
Yeah, the one I have is a tubeless. So there are some that actually come with tube lines that actually, so the apparatus themselves it's something that you can carry or clip on your belt. And then the tube is running through a site on your arms, your legs, your belly. So the two are attached. I chose the tubeless just based on my lifestyle and just the choice that I made. And so far, it's working out good. And this is a side note. So again, I'm 43 years doing this daily injection thing, but I used multiple daily injections, so syringes, insulin pens, for 42 years. So I just recently went on a pump. So I'm 1 year now on this insulin pump. And that took a little bit of adjustment, obviously, because you're doing well with what you're doing. And then suddenly it's like, you know what? Yeah, this is the right time. I was curious. It helps me to better kind of communicate and relate to my clients, obviously. It just kind of puts coaching on a different level when you yourself are wearing a pump. But yeah, it's amazing. And there's different types of pumps out there. So they're not all exactly the same. Many of them do sync up with a continuous glucose monitor. And again, the systems are so obviously the CGM's giving the pump the blood sugar information. And if it's on an automated delivery system, then the insulin pump, is basing its dose on the CGM data coming in. So the blood sugar data coming in. And
So
it's not, yeah, it is. It's really cool. It's not hands off. You're still aware of what it's doing. You can definitely, there's a lot of settings that you come to terms with. You and your doctor decide what those insulin to carb ratios are and your basal settings. Those are all, I know, some terms that maybe your listeners aren't used to, but those are all the things that we have to consider when we want to stay at a certain level the day and night. Yeah.
So the continuous glucose monitor, this little quarter size thing that you slap on your arm, it doesn't hurt. It's got a tiny needle and measures the interstitial
Yeah,
fluid in the arm.
absolutely.
And we keep it on for 2 weeks, more or less. Some they're different.
Yeah.
So how with the insulin pump, does that hurt or not hurt the same way? And how long do you keep it for?
Yeah, yeah. The pod I wear is a 3-day wear. So every third day I change it out. And it's good to rotate because, again, over the years, our body and scar tissue can build up if you continue to use the same site. As you can imagine, if you're putting it on the same part of the arm day after day, it's going to just not work as well. And there's going to be some irritation there. So you got to get creative. You got to move it around. So I wear it on my arms, my stomach, my hips. A lot of people in the community wear them on the legs. I haven't done the legs yet, so I'm still graduating to the legs maybe one day. But yeah, that's another whole part of it because it's important to rotate and to find your optimal spots. We all have spots that are when it's inserted that it's actually your body's optimally absorbing the insulin, the absorption rate. Because obviously, if it's there, you want it to work properly and you want your body to get what you want it to get. So you don't want those site failures and all of that. So there's a lot of little things that a lot of people don't realize. All these little things we got to think about and change and the data that we're looking at for the feedback in order to decide what's working, what's not working, what to talk to the doctor about, and
Does
different
it
things like
hurt?
that. It does pinch a little bit. It sure does. Yeah. Yeah. The needle's a little bit longer than the CGM. The CGM is as just a filament and it's still incredible. To this day, all the years I've been wearing a CGM, probably 15 years now, it still blows my mind of the technology.
Mhm.
I mean, it's something so insignificant looking can give you so much information. It just still blows my
It blows my
mind.
mind. I'm waiting for them to come out with
I
one that measures your
know.
hormone, your cholesterol
Yeah.
levels. Like, I can't wait for that to happen. But there's so much. When you mentioned insulin is a hormone. So when I tell women we need to check our hormones, I'm not just talking about progesterone, estrogen, testosterone. We're also talking about
Yes.
insulin and
Insulin
blood
levels.
sugar as well. It's not a
Yes.
hormone, but these are important things to look at as we're going through menopause.
Yes.
And as well, actually, insulin is a peptide, and in the biohacking world, we're all into peptides. So I'm wondering,
Hmm.
are there any peptides out there that diabetics can use to help improve their blood sugar?
That's a great question too. GLP-1s are starting to get more attention in the T1D, so that's a type 1 diabetes space. They are being used, as you know, in more of the metabolically challenged, which is the type 2 space. We are seeing more and more doctors opening up that possibility. So again, give it time. It's again, I think it's very individual. It's not something I'm looking at. It just because I have everything in place. So I don't just bring something in just for the sake of bringing it in. It really, I think it's an important opportunity to ask why. Why do I need this? How will it help me? What's the benefits? What's the risk or the pros about maybe bringing a GLP-1 is? But again, if it's done in a very responsible way, again, lifestyle, you got to have that foundation built first for all this to work optimally for sure.
So I am wondering because there are a lot of benefits that come with the GLP-1. And aside from the weight loss, most people are taking them for weight loss. But there are some people who would say, oh, I'm taking it for inflammation. They don't seem to need to lose weight. And you don't look like you need to lose weight either. But if you said, this is really going to benefit my blood sugar, I will need less
Mhm.
insulin or not. Is that something to consider?
It is. It absolutely is. I've had a few ladies on my show talk about this. Again, they're not looking for the weight loss either. Again, they're using the microdose and they're doing it very judiciously. And it is to help with insulin sensitivity. So it's just to make the insulin that they are using more available, more sensitive, more sensitive. I love the word sensitive. It's working. Your body's responding better to it. And there's a lot of other hormones in the pancreas. There's the leptin and there's the ghrelin. These are ones you know of. And amylin is the other one. So the GLP-1s are really helping that end of what we may be struggling with living with type 1 diabetes as well. So there might be a shortcoming with our amylin levels. So that's really the body's ability to tell us that we're full and the satiation and all of those things. So I've heard a lot of people that are on them. It does kind of quiet that hunger noise that they're hearing. And yeah, it's again, it's just so individual, but there are some benefits. And it's exciting to see more and more information coming out and to see and like I was saying, the ladies I've met, actually they're both registered dietitians that have been living with diabetes for years and they're in their 40s and they're just starting to come up on perimenopause. So again, all these things that are affecting our insulin sensitivity. So they're being very proactive in their approach. And they're really fortunate to have doctors that are willing to jump on board with that and to give them what they think is going to help for sure. Yeah.
It's almost like there needs to be a GLP-1 or something that could help with the insulin, but yet not make you lose weight. Because if you are
Yeah.
like you, for example, you're dialed in with nutrition and exercise, like you don't want to lose
Right.
weight, but you may go, hey, I want to be able to improve my insulin
Right.
sensitivity.
Right.
So that's something an interesting space to look forward to if there is any merit to that. But is the game to use less insulin or need it less? What's the objective?
I like where you're going with this because that's always been my objective. I think our diet and lifestyle really does determine everybody's need for insulin. And ideally, we want low insulin levels. And again, that's another important marker. A lot of doctors, and I'm seeing this a lot in the perimenopausal space. I help women locally that don't live with diabetes, but are giving that pre-diabetes scare. Again, they're in their 40s and 50s. It's all coming at the same time. but they're only getting their glucose number checked and they're getting their A1C maybe checked. And the doctor's saying, oh, you're good to go. So I'm pushing back and encouraging them to get their, and I'm sure you've heard of this, their fasting insulin level checked.
Tell
And
us why that's important.
that is the true measure of what's going on because you really want to operate on as little insulin as possible. So I believe the guideline is 5 milligrams or lower, again, optimally. So we want that number. Again, if you're living, this is not for somebody with type 1 because that would be kind of an oddball test for those of us with type 1. That test would not come back with any sort of merit to it. But just real important. I think it speaks the whole story. And it's interesting when those tests come back a little high. Let's say you come back with a 10 or a 15 level of insulin. And I've seen these test results. So a lot of my clients come to me, we look over their labs. Again, I can't prescribe or direct or give them any medical information, but we can look at them together and I can say, well, this is what I'm seeing. The doctor didn't point it out, but I say, well, and we'll talk about it and I'll send them back and they'll go back to the doctor and say, what about this? What about this? But in most cases, their insulin levels are high. Their A1C might just be okay, but again, their body's working really hard. It's producing a lot of insulin to get to that 5.2 A1C, which is optimal.
What's
But you,
tell us when you say A1C, some people hear
yes.
HbA1c. Tell us a little bit what that is.
Yeah, the same one. So, yeah, so that's a standard test that they can run that is basically giving you the average blood sugar over a 3 month period of time. And if you do not have diabetes, 4.8, 5.3, those levels jump around a little bit depending on what lab you're looking at, but that's ideal. But again, if your body has to produce a lot of insulin to reach that level, but you're still gaining weight, your cholesterol's going up, all these other things are happening, then they need to circle back and say, okay, so what does your diet and lifestyle look like? Okay, because that's really the true story rather than just putting you on a statin or metformin or whatever that,
So actually, so somebody is going into
pharmaceutical.
the doctor, they're feeling tired, they're gaining weight, they're having these symptoms, and they said the doctor checks their HbA1c and says, "Oh,
Hmm.
well, you're fine." You're saying, "No, go back and get a fasting insulin and let's see
Absolutely.
if
Yes.
you
Yeah.
are just not, you're putting out, your body's on fire. It's trying to get
Right.
so much insulin in your body
Yeah.
to pull out this blood sugar, which is likely due to the foods that you eat, but also I understand, I mean, that chronic stress
Yeah.
can also
Absolutely.
raise your blood sugar. That's been always the number one thing that shocks my community when we do
Hmm.
these glucose monitor
Yeah.
tests together and we're focused on the food. Exercise also increases it, but then over time helps bring blood sugar down. But this, I didn't eat anything, but I exercised. Oh my God, it's going up. But the
Right.
stress piece, when they say, I swear to God, I didn't eat anything at 11 p.m., but yet had an argument, then you
Hmm.
see your blood sugar go up. And that's pretty scary because it has nothing to do with the food that you eat.
I know. Yes. And that goes back to all the things that we have to look at with type 1 diabetes because, yes, we're counting carbs, we're injecting insulin, but just how you just pointed it out, there's so many other factors that are going to determine what our body's going to respond, how our blood sugar is going to respond. So the sleep, the cortisol, the type of exercises, because there's stress-inducing exercises. It's funny you bring that up too, because I'll do some cardio, I weight train, and generally, weight training will bump me up. So I might spike 30, 40, 50 points just doing some heavy lifting for 30 minutes. And I don't always remember, but I should always remember. And you get in the middle of your workout, 30 minutes has gone by, and I look at my CGM and it's starting to go up. I'm like, darn it. All I needed to do was tell my pump to give me like a half a unit. It's amazing. You just need that little bit to curtail that cortisol spike because your body is doing that naturally. A healthy working pancreas is there to keep you level. So it's interesting, but that's the liver just dumping the glucose and it's there to protect us, even though it's aggravating.
Yeah.
But it's
It's, you're
understanding
here,
how it
you are
works.
doing something good for your body.
I
And
know.
yet the blood sugar goes up, and that's interesting. So with
Yeah.
us or not anyone else, your body would do that naturally, but for you, you got to program things or
Yeah.
rely on an automated system on your insulin pump to take care of that for you, correct?
Absolutely. Absolutely. Yeah. Yeah. That is how it all can work together.
Okay, this is super interesting. We only have a little bit of time left, but I want to know how menopause affects women with type 1 diabetes differently than those who don't have type 1 or
Yeah.
type 2 diabetes.
Yeah, and it does affect all women and it does affect all women's blood sugar. So the difference is we have the CGMs on, generally speaking. So we've gotten the data. So we're seeing that our insulin needs are going up. This is when estrogen starts to fall. So generally speaking, around age 40, I have some women that I've worked with late 30s, they're starting to see that influence and that they need more insulin. They're not as sensitive to what used to work is no longer working. So we do have that advantage when we have the data to give us the feedback, but it's very profound. And that's really what I'm doing now. And that's when I've really turned my podcast and my coaching is all directed to just what you were just asking me about. Is that why is it different for those of us with diabetes? Because it's drastically different. So those chaotic hormones in perimenopause, when the luteal phase and follicular phase are just tossing estrogen and progesterone out at different times and levels, well, that impacts our blood sugar. So again, low estrogen. So as it's starting to fall, progesterone falls kind of side by side with that, but estrogen really does have the influence over blood sugar. So as that's falling during certain times of your cycle, if you're still cycling, it is profoundly impacting blood sugar and our need for more insulin. And there's not a whole lot of support or data out there to prove this. There are some research studies that are happening now. It's not happening fast enough just to prove it to the community, to be able to educate the doctors, to be able to better support their patients on this. But that's truly why I'm doing what I'm doing is just to create the picture and spread the awareness. And I think living with this disease can be emotionally taxing, as you can imagine. And then when you add on what hormones do to our sense of self and emotional well-being, and you're still managing a chronic disease along this, and then you have a practitioner that's just telling you, well, increase your insulin, get over it. You're getting older. This is just the way it's going to be. This is not the way it needs to be. So again, the conversation with hormone replacement needs to be in the endocrinologist office. It's not happening yet. There's very few that are educated with that. And it's such an important part of, again, a opportunity for women to know, understand what's going on, and to make this choice with hormone therapy if that's something they choose.
I
Yeah.
find it amazing that you can measure what we preach. So anybody in the menopause space or has a voice talks about, yeah, women generally get more insulin resistant as we go through menopause.
Hmm.
And I guess there's some research there just with people who do not have any diabetes. But
Sure.
what's interesting is that you have a whole community of women who are you are one big experiment. You
Yes.
see that
Yes.
you need more insulin. That shows that you're
Yes.
becoming more insulin resistant. You're proving
Yes.
it
Yes.
in your own
Yes.
bio experiment. And
You're
it's
so right.
incredible.
Yeah.
So I think
Yeah.
that's a real, I don't want to say an advantage, but it's just a proof that what we're
Yeah.
saying is you see it with your own eyeballs, which is incredible. And you're working with women in a community, so you can see this yourself time after time, not only
Abs-
with your own body.
ab-
It's pretty amazing. But what you're saying is that for my first thought was, hey, well, that's lucky you. You just put in more insulin and you can eat. You don't have to change the diet and lifestyle. We have to do these things. But I think what you're saying is that's not the point. Is that right?
Yeah. The point is, it is the unpredictable end of it. So I think that's what, I mean, we get into a rhythm with knowing how much insulin to take for meals, exercise, time of day, or whatever. And then suddenly, when the hormones are just completely out of whack and logic does not play in anymore, and there's this variable called estrogen that is suddenly a big part of that story. And unless a woman understands that, it can really be detrimental to her everyday care. It impacts us. Blood sugar is hard enough to balance and keep level without this outside influence that we don't understand how to interpret or to change or to make decisions around. I think that's really where the hole is that disconnect. And it is frustrating to see that this has not quite happened in our menopausal space right now. I'm hoping it will be. Give it time. But, and it's just a good example that we have to advocate. It's important that we do our own research, study ourselves. We are our own best study guides, right? Or guinea pigs, whatever you want to call it. And just to trust it and to follow your symptoms and to ask questions. It's just so important. Yeah.
So having insulin pumps or injecting yourself with insulin isn't a free pass to do what you want to do, is it?
Not, I think that that's a good question because I think it depends on the woman or the person living with diabetes. And many of us don't want to kind of guessing more about what to do every day to take care of ourselves. So I don't think we want to just take more insulin. I don't think we want to give in to the fact that we really don't understand how our body's operating. I think that's really what happens when you live with this disease for so many years. You get in sync with it because you tend to know your body and how it feels and what works and what doesn't work. And then when hormones are no longer there to support us on a cycle throughout our reproductive years, it's really hard to swallow. And again, it's different for every woman, but I think just the information and just being able to better understand the why and ultimately understand some things. You mentioned GLP-1s. That's something that women in menopause with type 1 are bringing on because of those reasons. It's helping them get through the perimenopause stage. Some are doing hormone replacement like I did and continue to do. Some are doing metformin. That's another whole mix. We don't even talk about metformin, but that's another one. Again, it's helping with insulin sensitivity. Yeah, so there are some things that can be looked at. And again, empowered. We're here and we should truly be in charge of our health and the choices that we have in front of us, hopefully.
So we know that HRT or hormone replacement therapy, and hopefully we're talking about bioidenticals,
Mhm.
help a woman through this transition and can help with the blood sugar levels as well. It's not the only thing. We always say you got to do the diet and exercise
Yeah,
and sleep and stress management. But
absolutely.
do you see that women who have type 1 diabetes respond differently to HRT?
Oh, yes, yes. And I saw this in myself. I noticed I had to go to my doctor asking about it. Again, I did my own research about HRT, bioidentical for sure. It's all about the source and all of that. And the source that it comes from is really, really important. But I had to go to the doctor with this idea. It wasn't offered to me. And the connection between the two hormones, because it's two, all these hormones work together and we do what we can for them to work the best together. But I think with especially those of us with type 1, it's just really important to understand that. I'm not sure if I'm answering your question. I forgot. I think I forgot. I think I kind of did a tailspin there with that, with my answer. But yeah, it's hormone replacement was a game changer for me. I was having a lot of symptoms in my early 50s. I'm 58 now, and I didn't even know was related to my hormones. I had the vertigo, I had the frozen shoulder, I had the dry skin, all these things that sound like they're not a big deal. Well, frozen shoulder was a big deal, trust me. The sleep, the 8 pounds around the middle that just seemed to come from out of nowhere, doubling my basal rate. This is when I was doing my daily injections. So I went from 9 units a day. And I know this is a number that maybe the listeners don't understand, but 9 units of basal insulin. So this is a 1 day shot. So I went from 9 to 15
Oh, wow.
units. So nearly doubled within, again, it was a slow gradual. It wasn't overnight, thank goodness, but we notice these difference. We notice when 10 units is not quite enough. Oh, I got to up it to 11. Oh, I got to up it to 13. Okay, so when does this stop? What is the reason why? And that's when I kind of put it together for myself that it really had to do with the estradiol that was pretty much doing a nosedive in my system, understandably.
Do you know if
Yeah.
menopause is any different for women with type 1 diabetes in terms of either symptoms or the menopause birth date? Do you go into earlier or later? Is there any data on that?
Yeah. That's something they're researching, but there is no data back on that. Again, women's health, as you know, has not been looked at too closely. There is no research on it. There's a lot of theories about what time you were diagnosed. Again, there's a genetic composure. I don't see any really direct connection. Now, from women I'm meeting, I am meeting women again in my community who are early to mid 40s who are, and because my symptoms didn't show up until early 50s. That was just where I was. But they're 10 years younger than I was, and they're already starting to see these symptoms. Sleep is probably the number one, the sleep disruptions. And even night sweats is already starting, and that disruptive sleep, waking up hot. And that's kind of the funny one because you wake up hot, or is it your blood sugar or is it your hormones?
How do you know?
Or is it both? So that really can make you feel like you're going crazy. So yeah, it's different, but really too much, very similar to those of us with type 1 diabetes. But the onset is still kind of a mystery as far as, yeah, if it's any different.
So you mentioned that you can clearly see you need more insulin when you're going through menopause and the hormones are all going crazy. So what happens to a woman's blood sugar levels and the insulin necessity as she gets on hormone therapy?
It's a slow process. And again, slow is good. There's nothing worse than waking up and saying, oh, the estrogen patch I put on 3 days ago, I'm suddenly crashing with low blood sugar. So again, as we know, it slowly gets into the system. It's pretty magical when you think about it. It really does. It's another one of those things that just makes me go, wow, it's incredible how impactful estrogen is for insulin and how they are so closely related and tied with how optimal it can either help you or not help you. And obviously the levels matter. We've had some ladies, and myself included, I've had to over the years, I started at a lower dose, how they say low and slow, which is a good idea. And I'm up to 3 milligrams per day now. I do the cream, estradiol compounded cream. And again, it took time to get there to kind of dial in what feels good. The symptoms are getting more and more starting to dissipate. I remember I guess I was doing 2 milligrams for a while. And then suddenly I was just starting to get the night sweats again. That just started to ramp up again. And I'm like, oh, but it's nice when it's so obvious that you can see the difference. And I was needing a little bit more insulin. So those tend to be the two things that we see primarily with type 1 diabetes is our blood sugar and our sleep. And the night sweats tend to roll in there. Again, it's different for everybody, but those are obvious symptoms that it's kind of like the flag gets raised. I think I might need a little bit more. Yeah.
So, with the women in your community that you're helping, and as well as yourself, do you see that once you go on the hormone therapy, over time you need less insulin?
Yes, this is what I'm saying.
Yeah.
Absolutely.
Okay.
Absolutely. Yes. And that definitely helped me. Yeah. That's
So
definitely,
interesting that you can see and
yeah,
measure these things, like with just witness it with your own eyes without doing any kind of major scientific experiment. But you've got your own
true.
lab, your body is your laboratory, and the CGM and is all the data. And it's just so cool. I
It
highly
is.
encourage anyone who, no matter if you have diabetes or not diabetes, well, if you have diabetes, you have to take a CGM. But if you don't, get one of these CGM monitors, these continuous
Yeah.
glucose monitors, and put it on yourself for 2 weeks, and you're going to see how your body reacts. And I always see
Yeah.
people are different. We're not all the same. And you'll learn something new with your body for sure. It's one of my favorite experiments to do.
Uh-huh.
But I'm going to have to let you go now. But I know that you are writing a book. It's coming out next
I,
year.
yes. And it's something I'm very passionate about. This is something, it is called, I'll give you the title. Highs, Lows, and Hormones. So it is going to be a survival guide for women with diabetes from the monthly cycles to menopause. And I decided to open it up because it's interesting. When I first started to write and just create the content, I was so focused on just menopause because, again, that's where I'm at. But I'm like, you know what? This really does start at the beginning, and that is with our monthly cycles. And there's so many women in our community of all ages living with type 1 who struggle with, and we didn't touch too much on this, but these are things I was experiencing in my reproductive years. Depending on the cycle time, when our estrogen is low or high, peaked or not, there was that was influencing my blood sugars as well. I just wasn't aware. Again, wasn't
Amazing.
told, didn't ask, didn't know the connection. So this book is really going to be a comprehensive guide for all women to refer to. And I have two contributors that are coming in. As a doctor that I've gotten to know, and she also lives with type 1 diabetes, and she works in the OBGYN space, and she specializes in hormone therapy. So I'm just beyond the moon with the expertise that is going to put all of our stories and facts and direction in a book that women can truly use. I'm just very excited for this opportunity. So,
Oh,
yeah,
I
thanks for
love it.
asking.
I will make sure when that comes out, I'll put that in the show notes and when you're ready for that. But I have everyone just got to go and listen to your podcast, Type 1 in Midlife. And I'll have a link to that in the show notes as well.
Thank
And you've
you.
got YouTube, Instagram. People can find you so easily and learn so much. But I'm so grateful that you created this community for people who really need it because you are different and you need maybe a different approach to menopause and
Yeah.
HRT and all that stuff. So people, if you're listening, I got to the end, please go and follow Melissa and you'll find out a lot more about how to get through this transition. So thank you, Melissa. And
Thanks, time and space. I appreciate it.
and thank you everyone who's made it to the end and we'll see you next time. Take care.